Thanks, Emmett, for that great presentation. So we're now going to hear Chris Boshoff, who is the Senior Vice President for Immuno-Oncology, Early Development and Translational Oncology at Pfizer, and we'll hear the Pfizer view.
Thank you very much, Samir and Roger, for organizing with our colleagues at the National Academy. So I'm an employee of Pfizer, and immunotherapy is not one of our big anchors, but it is one of the medicines we're trying to develop and combine with current Pfizer medicine. So I will provide insight on how we're currently choosing combinations for registration intent studies. I'm going to use three examples. Firstly, to follow up with the Immunotherapy presentation, discuss the role of anti-VEGFR or VEGFR inhibitors and how these potentially could be combined with immunotherapy. Looking at one of our anchors, Palbociclib, Ibrance and breast cancer, and how we can potentially combine that with immunotherapy, and then using real-world data to look at the potential synergism or additivity between immunotherapy and a PARP inhibitor. For the VEGFR inhibition, the example we use is using modeling, statistical modeling to look for additive activity. For randomization, we use for our Palbociclib early on in a phase 1b study to determine whether there's a role for combining immunotherapy with CDK4/6. I'll give an example of each. So VEGFR, as just pointed out, VEGFR receptors are expressed on most immune cells, specifically VEGFR2, highly expressed on T regulatory cells. We have a VEGFR inhibitor called axitinib, or Inlyta, is approved in renal cancer. It's a very potent inhibitor of VEGFR2. There's various other reasons why it makes sense to combine an anti-VEGF antibody, as we've seen with the data from Genentech with bevacizumab, or a VEGFR inhibitor with a checkpoint inhibitor. So we conducted a phase 1 study with a PD-L1 avelumab plus Inlyta or axitinib in first-line RCC, where we saw encouraging early data. The majority of patients responding, overall response rate, updated data over 60%, with complete remissions approximately 7%. So these data suggested that these two drugs at least can be combined in terms of safety, and also there is potential for additivity. However, is this enough data to launch a phase 3 study? As we've heard, the example with epicadostat plus IDO1 and many other of the combinations currently being tested in phase 1 studies, these are single-agent experiences. Very difficult because patients are selected. We just saw recently, for example, in RCC, a response rate with single-agent pembrolizumab of nearly 40%. So it's very difficult in a phase 1 study on a single-arm experience to know whether there's real synergism or additivity. So what we did with this example, because sunitinib will be the comparator arm, an approved therapy in first-line RCC, is also Pfizer medicine. So we have a lot of data on patients' outcome with sunitinib. So we could use sunitinib and model what were the responses, the dynamic responses over time with sunitinib versus what we are seeing in the phase 1 study with avelumab plus axitinib. So why are we using avelumab plus axitinib and not avelumab plus sunitinib? A study has been done combining a checkpoint inhibitor plus sunitinib, but the side effect profile is challenging. So axitinib is therefore chosen as a combination partner for this immune checkpoint. So in light green on the left are all it's a spider plot and all the data for sunitinib from previous studies. The dark green dotted line is the average change in tumor size to sunitinib in first-line RCC. And then in dark red is the combination of axitinib plus avelumab, and in dark red dotted line, the combination the combination of axitinib plus avelumab, the average decrease in tumor size. So what we can see, a deeper decrease in tumor size, an earlier decrease in tumor size, providing some statistical data, at least for us, to proceed in a phase 3 setting. Also, we've conducted a phase 1 study with axitinib plus pembrolizumab. These data were recently updated. Overall response rate is just shown by Emmett, now over 72%, very encouraging early overall survival data in this phase 1 setting. And Merck has proceeded with a phase 3 study of axitinib plus pembrolizumab. So this is currently the landscape of studies ongoing in first-line RCC, with a recent readout for bevacizumab and atezolizumab, the other cabozantinib, levantinib, axitinib, plus pembro, axitinib, plus avelumab, all being compared against sunitinib, and we should see the phase 3 readouts, all of these during the next 6 to 12 months. Of course, recent approval for nivolumab plus ipilimumab, but specifically in a subgroup of intermediate or high-risk RCC. One thing I need to point out is one of our challenges in the field. If we look at these studies, all of these studies, apart from the phase 1-2 study with the IL-2, all of the other studies, phase 3 studies, against sunitinib. So over 2,000 patients during the last 3 years have been randomized against sunitinib. So hopefully in the future, we can all work together and use this database of sunitinib outcome in these phase 3 studies to use as a potential synthetic arm in the future. Not all of these studies will necessarily replace sunitinib. We know from the bevacizumab and atezolizumab data, there are subgroups of patients who actually could benefit from just having a single agent anti-VEGFR or VEGFR inhibitor like sunitinib. If we use the next example is very early on doing a randomized setting to determine whether there's additivity or synergism. As I mentioned, palbociclib or Ibrance is one of our anchor medicines we're developing in breast cancer, ER-positive breast cancer, now approved in various settings of ER-positive disease. It's a CDK4/6 inhibitors. We all know that CDK4/6 inhibitors bind with cyclin D1 or D2 to block cells in the progression from G1 to S. So essentially blocking cell proliferation, something that's essential, that's a basis of all cancer, cell proliferation. What was seen in the early studies with palbociclib, these are data from UCLA, is that ER-positive breast cancer or luminal breast cancer, very low IC50, meaning low dose palbociclib, blocked these cells proliferation. And then, of course, this led to phase 1 studies and eventually phase 2 and 3 studies that led to the approval of palbociclib with either letrozole or fulvestrant in various settings of ER-positive breast cancer. From the beginning, colleagues have been asking me and externally, why are we not combining palbociclib with the immune checkpoint blocker? Now, of course, CDK4/6 is essential also for the proliferation of T cells. So for me, it was not a rational combination because essentially we also had preclinical data that palbociclib blocked T cell proliferation, so it doesn't make sense. However, during the last couple of months, a number of high-profile papers have appeared indicating or inferring that a CDK4/6 inhibitor could potentially create an immunogenic microenvironment. So, for example, in this paper shown with abemaciclib, the Lilly CDK4/6 inhibitor, it suggests that a CDK4/6 inhibitor can actually lead to the upregulation of endogenous retroviruses and then stimulate, by way of that mechanism, an immune response and the presentation of tumor antigens. A separate paper has suggesting with palbociclib, again, suggesting it's additive with an immune checkpoint blocker in this preclinical model that a CDK4/6 inhibitor maybe bring T cells into a tumor and could activate T cells. We therefore decided, okay, we'll proceed and we'll test this hypothesis in a very early study, phase 1b/2 study, but very early on in a randomized setting to really understand the role that a PD-L1, in this case, avelumab, could bring to this combination. This combination is currently being tested in tumors that's previously received and progressed on palbociclib. So this is also testing a separate hypothesis. Can you use fulvestrant plus palbociclib post letrozole palbociclib? So testing CDK4/6 post CDK4/6, as well as the additional arm, the hypothesis of fulvestrant, palbociclib, and avelumab. So we believe this is a rational. We're doing this in collaboration with Erika Meyer, Dana-Farber Cancer Institute, that this is a rational way, rather than proceed in a phase 3 study, to very early on test, not having all the challenges with a phase 1 study or just a single-arm experience to know whether there's real additive activity, to test early on a randomized experience. The last example I'm going to use is using real-world data as a comparator arm. or as recently Rick Pastas stated, real-world data, we can always also put lipstick on a pig and call it a synthetic arm. But essentially, it's real-world data. So this is DDR, so-called DNA response, DNA damage response pathway defects. This includes genes that you're all familiar with, like BRCA1, BRCA2, other genes in this pathway, ATM, ATR, Fanconi, RAD51. These are all genes that we know that defects in these genes accumulate as we age, and they involve in inflammation and in aging-related diseases, including cancer and metabolic disorders. We now also know that cancers or tumors with defects in DDR can respond to a PARP inhibitor. So we do have a PARP inhibitor called talazoparib, currently with the FDA under priority review for breast cancer. So for us, it was of interest. Could we potentially test talazoparib in combination with an immune checkpoint? So what are other reasons why we want to do this combination? A couple of years ago, the Sanger Institute, it was shown that in breast cancers, those breast cancers that harbor BRCA1 or BRCA2 mutations do have overall a higher mutational burden than breast cancers that's ER positive or triple negative or just HER2 positive. And these are both subclonal and clonal in BRCA1 or BRCA2 mutations. Overall, higher tumor mutational burden, suggesting these breast cancers that could respond to a PARP inhibitor are also the breast cancers that could potentially respond to an immune checkpoint blocker. Separately, very elegant work recently published by our colleagues from Genentech showed that in bladder cancer or urothelial cancer, those bladder cancers that harbor defects in DDR pathway, these are all the genes that's in this pathway. So bladder cancers harboring defects in this pathway have a higher response to an immune checkpoint blocker, in their case, of course, the anti-PD-L1 atezolizumab. Again, suggesting that these bladder cancers responding to a PARP inhibitor are also the bladder cancers that appear to respond to an immune checkpoint blocker. And then separate work that was published that in lung cancers with BRCA1 or BRCA2 mutations also have overall a higher tumor mutational burden. Again, inferring that those lung cancers that could respond to a PARP inhibitor may also be the same lung cancers that could have a higher response to an immune checkpoint blocker. So there's a rationale for combining these two. So we started the phase 1 study, it's now in phase 2, and we're actually about to launch a phase 3 study combining talazoparib plus avelumab. These are early data, for example, in ovarian cancer, although we can't say here in this specific case whether this patient is responding to the talazoparib or to avelumab, but it's early encouraging data also in terms of the safety for combining this. Specifically, we've also launched a phase 2 study, tissue agnostic, any tumor with a BRCA1, BRCA2, or ATM defect are treated with a combination of talazoparib plus avelumab. And for this study, we are using real-world data to look at not specifically as a control, but really to understand what is the outcome of patients, any tumor type, whether it's bone cancer, bladder cancer, breast cancer, brain cancer, melanoma, with a BRCA1, BRCA2, or ATM defect. What is the real-world data for such patients? What is their outcome? What is the responses of these tumors? And then we can compare to our ongoing phase 2 study combining the data in avelumab and talazoparib. So these are just 3 examples I've given you for early data, early randomization, real-world data, or modeling or simulation to detect early signals whether we should proceed with a phase 3 study. Some of our ongoing studies, I need to point out, I mentioned avelumab. We also have an anti-PD-1. It's being developed as a subcutaneous formulation, 4-weekly currently, potentially also 6-weekly. That's currently being developed in combination also with our vaccine-based immunotherapy program. In red are all the ongoing phase 3 studies. We do collaborate. So Pfizer provides, for example, Xtandi or enzalutamide to Genentech, to Roche Genentech for their phase 3 study that's being conducted by Roche Genentech in castrate-resistant prostate cancer. We're also providing Inlighted to Merck for their ongoing phase 3 study with pembrolizumab in first-line RCC. In pink are all the targeted therapies at Pfizer currently approved or under review, and then some of the external collaborations ongoing. Thank you very much.